about the determinant. Why we are talking about determinants? Like if someone is non-employment or unemployment, sorry, if someone is unemployed, it can cause depression, anxiety, a lot of distress and all of that. So this is one of the determinant of the health factor. If someone is employed, we assumed, I'm not saying that 100% all of the time, we assume they are living a good life, or we assume they are not depressed. Okay. I mean, in that cases, we do assume, but in the again, we do ask question, we do take history and all of that. So this is one of the determinant of the health. So then the childhood experiences, physical environment, and social health behavior, access to the public health services, how often they can go to a doctor and get their medication. That's also one of the things. Biology, and then genetics, gender, culture, exposure to the colonization, how much they are facing the racism, prejudice, the racism. So these all are all the things that work together as a determinants of the health. If they are experiencing even any one thing, they will be having some sort of psychological, physiological, or any kind of issue going on. Then comes the health equity. When all people have the opportunity to attain their full health potential. So this is basically now everyone is equal, and everyone is, like how I say, 10 people come to the clinic and 10 people are able to see the doctor. Okay. So this is basically called health equity. It's not like, okay, you are more serious, you will be seen, okay, you come tomorrow. It does not work like that. This is called health equity. Every person got the opportunity to attain the full health potential, although someone has serious issues or someone has the other issues. Okay. So disadvantages from achieving this potential because of the social position and the other socially determined circumstances. Like, you judge people, okay, see, he's black, okay, he has to see weight more. So it does not work like that. Then comes the health equality. Health equality is defined as the where population have equal or similar health status. And health equalities are systemic differences in the health of the groups that do not necessarily carry a moral judgment. So if someone goes to the emergency medicine, the more you behave like, you have a problem, you will be seen more early. So now this is basically because we assume that he is more severe or he is in more pain, he got more attention and more early attention. So that's what they're talking about. Have the equal and equal health concerns or status, but when it comes to judgment, the moral judgment is the one we decide that this which person will get first and which person will get second. Okay. Then the definition of health. A definition of health is so many. So you can read this one. What I like to read is just the inverted commas part. State of, please, physical, mental, social. So not just physical, not just mental. It has to be social too. Okay. If someone is introvert, not talking, blah blah blah, then something is wrong. Okay. State of complete physical, mental, social well-being. I'm talking about those person who was first talking to people and now he's avoiding. Now they are suffering with something. So in that case, I'm talking about so physical, mental, social well-being, and not merely the absence of the disease or infirmity. So they are talking about that there should be some sort of disease going on, but at the same time, it should be affecting physical, mental, and the social well-being of them. Then again, when we are talking about the who, because if they give you a MCQs that says define health, and then there is a long straight lines and you have to choose between them. Sometimes they put, okay, a patient's complete physical and mental health is not good because of the disease. Is it health? So it does make sense to us. Okay, yeah, physical is disturbed, mental is health. Sometimes we forget about social one. So social one is part of the definition. It's an important factor of the definition. Okay. So then we are talking about the who definition. Who definition is kind of long. It's very important. Okay. The ability to define and to realize the aspirant to satisfy needs, to change or cope with the environment. Health is therefore a resource of everyday life. Okay, it has to be everyday life, not the objective of living. Health is a positive concept emphasizing, again, I said social, personal, as well as the physical capabilities. So, social is very important. Please don't forget about the social part. Okay. Then again, you can see which one comes first, the health determinants. We already talked about the health determinants. So please look into that one. Each and every single word of the health determinants is important. It can be asked, okay, what are the health determinants, and they give you a line, give putting all of them together, this one, this one, this one. If you don't know, how will you answer that? Okay. So health is a social, economic, and then political issue, and above all of the fundamental health issue. Just for your understanding, remember the name: cultural humility, cultural safety, cultural awareness, cultural sensitivity, cultural competency. If you want to read inside it, go ahead. It's not too much that I can say. Okay, now we are talking about the Ottawa Charter of the Health Promotion. I know this is kind of very lame to remember, but yeah, this is very important again, because there was one of the question in MCC practice test from here, from the Ottawa Charter something. So that's why you need to read this one. Health promotion, the process of enabling the population, people to increase the control over and improve their health. So usually the Ottawa works together to improve that one. Some population promotion can be achieved through the clinical interaction with the patients, but most health promotion is done to the population by the public health professionals, agencies like, family medicine, public health, they all work together. State hold policies, they all bring it together. What is the main charter states? Okay, so this one they are talking about the how the health promotion works. So the charter states, this is the last point. Okay, if you cannot read the top part, it's fine. I wouldn't mind that one, but at least you need to read this one. What does the charter say? Charter says that the government and the health providers should be involved in the health promotion. So government should work together with the doctors or the healthcare providers. How do they work together? For the building the public policies, like bringing more immunization, bringing more whatever it is, then creating the supportive environment so they can get access to all the things which are needed. Then strengthening community action. So if someone wants to go for the fit test, like I recently saw a guy who wanted to go for fit test, although he was 35, but what happened was his brother just recently got diagnosed in his 50s with the colorectal cancer. So do you think he's a candidate for the colon cancer? He is. Okay. At least he is eligible for fit testing. Okay. But there's one question that came to my mind for the screening point of view. Okay. So if there's a guy who came to you, he's 35, he wanted to do fit test because his brother got diagnosed with colon cancer at the age of 50 1 year ago. His brother is now 51. So is he eligible for that? So he's eligible for fit testing, not for colonoscopy. Okay. You can go for fit testing. I mean, although this is 10 years earlier than that, but for 35, yeah, you can put that, whatever it is. But now again, that guy comes, he's having mucus, blood, constipation, and unable to pass the stool, or incomplete defecation. And now his brother also got diagnosed with the cancer. In this case, do you think he's eligible for colonoscopy, or for other sigmoidoscopy or testing for that? So in this case, definitely, because he's having at this point symptoms. So it's best if he's seen by someone right away, as early as possible, before he got diagnosed with anything. Okay. So then developing personal skills, reorientation, health services, they all should work together on these things. Which one? Government and the public health. And this is what the Ottawa Charter states that. Okay. If you are missing anything, I wouldn't recommend missing this one. Epidemiology. Like, in your last whatever read, I would suggest at least read this one. Which disease is common in which population? We are talking about the indigenous population. Indigenous population, obviously, they divide into First Nation, Métis, Inuits, and all of those ones. So definition, you can skip that. Physical, they face racism, genocide, low income, violence, and unemployment. These are very straightforward things. Okay. Environmental. So because they can ask you, okay, in indigenous population, what kind of screening you would like to do, or what kind of test you would like to do. Okay. So in environmental, they got exposed with homeless, exposure to environmental toxins like poor drinking or disposal, or environmental stewardships. So all of those ones. Then in the personal risk factors, they are having problem with the lifestyle, low traditional unemployment facilities. The main problem is obesity. So we usually in the indigenous population after 35, we do just start checking their lipid profile. And 90% they do have high lipid profile because of their obesity. Then sedentary lifestyle, secondary poor nutrition, then high risk of smoking, substance abuse, and suicide is there. Then when we are talking about the population specific, the main thing is TB. Okay. In Canada, the main population that has TB risk is basically indigenous. If they say someone is or the some doctor or some health provider is working in indigenous community, which disease they are more prone to get is basically the TB, because it can be transferred through the airborne. So then they're talking about the health profile, which one are the diabetes, then interdisciplinary harm, substance abuse, smoking, cessation, language protection. So they are talking about all medicine to the traditional medicine to take care of the plan, and then all of those ones. Then we are talking about which population, black people. In the black people, they are more prone to socioeconomic status, immigrant status, and then Nova Scotia is more towards that one, and the new migrants, and they are having a problem with the racism too. So in this one, they have a problem with the mental and physical health. BMI is their high, diabetes and HTN. That's why we also do testing for these ones, and they also have problem with the kidneys too. So please keep it in your head. High risk of diabetes and high blood pressure in this population. So did you see that in the indigenous, the main concern is obesity, not diabetes or high blood pressure. Okay. But in black people, the main concern is high risk diabetes and high blood pressure. Okay, so the words are different. Obviously, the obesity do cause high diabetes and high blood pressure, but in indigenous, the main concern is obesity, but in black people, the main concern is the diabetes and high blood pressure. Then again, they do anti-racism and police and all that. Then comes the isolated seniors. Which one? The geriatrics, more than 65. What do they face? Abuse, emotional support is lacking, then hazardous tolerance, like, fall risk and all of those ones. Mobility issues, they have very, very important is mobility issues. That's why we check their vision, hearing, and their dementia and delirium, all those. Low hazardous control, and then the high risk of isolation and the mobility issues. So did you see the words that are important here? In the indigenous, the obesity; in the black people, the diabetes, and this one. In the senior people, the mobility issues, polypharmacy, like inactivity, and all of those ones. So please keep it in your head. So in that way, we are talking about the fall and injury prevention. So if you don't read it from here, you will miss a lot of things. Then we are talking about the children's and individuals, like, adolescents. So though we in those ones, they have low income, family dysfunction, lack of educational support, housing issues, unsafe housing, recreation space, and then poor supervision, food insecurity, and high risk behavior. So we talk about their safe housing and all that. Then people with the disabilities, in people with disabilities, obviously they have their own challenges, like, ADLS problem, substance abuse, poor nutrition, no one is there to take care of them, no income, no education. So in those cases, they do travel. So in that one, mainly that comes is basically trisomy 21. So we are talking about the Down syndrome here. New immigrants, which one are the one that's very challenging? So, and what do they bring? They have a smoke for fire, and then they also have a problem with TB. Then they have the cultural perspectives, obviously, what they learn and what they have from the back home. They are hard to have a problem with English. English speaking is one of their biggest language barrier, then cultural and then religious problems. Then women health, dental and vision, vaccination is very important to cover for them, especially in refugees. Then the cancer screening, language interpretation, and all the safety benefits. Then the people experiencing the homeless. In the homeless people, the alcohol is the issue. The other diseases, you have to think of all of those ones. Low income, food insecurity, and mental health. High rates of, so you can read the personal risk factors. So they are more at the risk of the personal violence. So they do have a problem with the violence. Okay, now comes the refugees. I have been talking about refugees a lot. So I understand, I hope you guys have an idea about the refugees. Refugees have so many problems, mainly the malaria, TB, and where they come from. If they're coming from Nigeria, that's different. They're coming from, and you need to know according to which demographic area they are coming from, which disease is common, especially the Nigeria, Pakistan, uh, Bangladesh. India, like mainly where they are coming from, then I think Uzbekistan, Iran, Afghanistan, at least from these areas, which are the diseases that is very common. And if they travel to South Asia, if they're traveling to the North America, which diseases are common? Because on the basis of that, they can be asked, okay, a 45-year-old guy wanted to travel to North America, and he's asking for vaccination, which vaccination you will offer. This also comes in epidemiology and it's not written anywhere. You have to do a little bit of search about that one. Which one is that one? And the most important areas are Nigeria, South America, North America. Uh, what else was there? Yeah, I think these are the one. If there are more, I will just remind that one and I will send in the group which areas that you at least you have to remember the vaccinations of those areas. Then the employment in English language learners, then chronically neglected populations, you have to talk about the culture, then religious, obviously they have the problem with the teaching, lawyers, and they don't go for the hijabs and Muslim females, Sikh problem, they all are that one. Then the LGBTQ, which are the high risk of the anxiety, depression, OCDs, phobic problems, suicide, self-harm, increased risk of alcohol, tobacco, substance abuse, PTSD, heterosexual, then the sexual diseases, HIV, socioeconomic status, and that all their different comorbidities. So mainly they're affected by the mental health. But again, don't forget about the MSM, like men sex with men can cause a lot of diseases too. So HIV and all of those ones could be there too. So then comes screening for poverty. What is a step one? So just read for the step one and step two. Step one is basically, do you have ever have the difficulty meeting the ends of the month? And step two is, have you filled out and sent it for the tax form? So you can see here, what are the tests you will do for the new immigrants to Canada? What are the medical exams? So please read this one. So mandatory exams are which one? Complete medical examination for all the people, chest x-ray and report for the person more than 11 year. Urine analysis, why we are doing the chest x-ray? For TB. Urine analysis for the person more than 5 years, then syphilis serology for more than 15, HIV testing for more than 15. Then the creatinine test more than 15. So you can see that compassionate psychosocial assessment, PTSD, you have to assess for all of that, PTSD, depression, intimate partner violence, and then immunization. Then again, we already discussed about the indigenous, so you don't have to go into very detail of this one. You're good. This is too much. Again, we talk about TB. Please keep it in your head. Indigenous people do cause a lot of TB spread. So keep it in your head. Then I think we already discussed about the disease prevention, how the primary prevention, secondary prevention, and then tertiary prevention. So please remember that there is 4 preventions, not just until tertiary. There is a fourth one too. Pathological onset, pre-symptomatic, and then clinical. Then comes the surveillance. We have to check for that, and planning, implementation. What are the types of surveillance? What are the different types? Passive and active. Passive is where we do, okay, someone comes to you, he wants to do the test. This is passive. Active one is basically where someone is already diagnosed and now the person got infected with that one. We have to test for that one and do basically uh, offer them treatment. Okay. Then comes the Sentinel. Sentinel is a selective reporting of the disease data from a limited network of the carefully selected reporting sites. So from one area, like, maybe from one area and then sending it to the other one. Well-designed system can be used to signal trends and outbreaks. So, if there is some maybe a diarrhea is outbreak in one area, so they have to collect the data and send it to the other one. Then passive prevention measures that the operate without the person's active involvement, like airbags, are more effective than active prevention measures that the person must be on their own, like wearing a seat belt. So this is called the passive prevention, like wearing seat belt and all that. So please, 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 for prevention, I would suggest here is the one: pre-modal, primary, secondary, and tertiary. So we are talking about the 4 1. If you cannot remember nothing, I would suggest please the examples. There's so many of them, especially for primary, secondary, and tertiary. We do mix up a lot of them. For me, I was very hard to decide which one is primary and which secondary, because in exam the way they portray the example, it makes me think that this is secondary or is it a tertiary. Okay. So pre-model is basically, where you educate someone, okay, please wash your hand, encourage an activity, before eating, wash your hand, and when you cough or sneeze, cover your mouth. So this is pre-model. Then comes the primary, where you are actively doing something, immunization, smoking cessation, seat belt. This is the one. Then when it comes to secondary is basically now someone in the family has cancer and we are offering them a mammogram or routine pap smear. Okay, so in that case, so they don't get any disease or any cancer or anything like that. So fit test. Tertiary, now anything already started, like they already have a disease, diabetes mellitus. In that case, is what the eye examination, foot examination, how the high blood pressure, checking for their heart disease, ECG, EKG. So all of those ones. So you have to see which level they are talking about. Believe me, the way they portray it, it's very difficult to find if it's a secondary, it's a tertiary. So, you have to be very careful about, like your understanding about the primary and secondary and tertiary, it's very important. Does the evidence support a supervised injection site? So, clinical question, do supervised, okay, this one is not important. Screening, so universal, selective, and multiphasing. So, someone said something. Is screening for cancer in average risk primary or the secondary prevention? So if we are talking about the average one, this comes in the secondary one. A primary screening for any kind of cancer, it comes in secondary prevention, like fit testing, offering anyone fit testing. This is basically and secondary. But if the same they say that someone's family history, someone got these things like, if a person comes to you and he has blood in the poop, mucus defecation or whatever, weight loss, all of those symptoms, in that cases, now this comes, if we offer him fit testing or something, colonoscopy, now this comes in tertiary because there is something already happening. Although we did not make a diagnosis, but we are offering him and doing a testing, this comes now in tertiary. Okay. So, screening types, at least remember the screening types: universal screening, selective screening, and multiphasic screening. Universal is doing for everyone, like how a child is born, we check for hypothyroidism, Down syndrome, alpha fetoprotein, and all of that. Selective screening only for the mammogram, like, more than 50, we do selective screening. Multiphasic, where there are many investigation and measurements to took for many of the disease entities like periodic health. So, growth chart for the children's, that is basically multiphasic one. Then comes the type of bias in screening. Oh my goodness. Then lead time bias, length time bias. Lead time bias is overestimated of the survival time from the diagnosis when the estimate is made from the time of screening instead of the later time when the disease would have been diagnosed. So since the time of screening, like, if it started from 50 years, we have started the mammogram. So we started it from that time. Okay, so he did the screening and we thought that, after screening, he got the diagnosis. So from the time of the screening, he got the diagnosis. This is basically lead time diagnosis. Maybe he had something before too, but we did not know that. And we did not want to assume that, or we did not want to say that. So overestimated of the survival time from the diagnosis. Since he did the mammogram, now we find it out that he has cancer. So from the time of the screening till how much it is going on. So maybe something was going on before, he has lesion, cyst, or whatever, but we don't want to say that this was cancer. So that's what they were saying. When it comes to the length time, overestimation of the survival time due to the screening at one time point, including more susceptible cases than aggressive cases of the disease, which maybe have shorter survival time. So they are talking about, usually for the length time, we think of, when someone presented for the first time with any kind of symptom and we did the screening at one time, but there wasn't anything going on. Okay. So in that case, it's like a more stable one than as compared to the aggressive one. So someone came to you at 30 years and we did mammogram. Let's suppose we did mammogram and nothing came out, but we started thinking of that one that he might have a cancer because he has symptoms. I hope this makes a little bit of sense. Otherwise, just keep it in head. The lead time is basically from the time of the screening to the onwards, and the length one is the opposite of that one. Okay. So This one you can at least remember one thing, and the other one is opposite to that. Okay. So this one you can see screening detected, occult disease. So there was an onset of disease, occult disease, screen detected. From here onwards is the lead time. So it started from here. Now this is clinically detected. Over disease, disease of the death. So this is basically now they are talking maybe this after that, or it started where the time of the symptoms, that is basically the length time. You never know how much the length was. They just assume the length by themselves. So lead time is very easy to determine. So you can think of whatever it is, at this time of the screening, you started the diagnosis until he is surviving time. So this is lead time. The opposite to that is length time. Okay. Ideal criteria of the screening test is basically when you do the disease, then test, and then the healthcare system. When we are talking about the disease, cause significant suffering or the death, naturally history must be understood, must have a asymptomatic, early detection and intervention must result in the outcome. Then the test is basically it should be high sensitive, as we already talking about. It should be test of the choice and safe, rapid, easy. It should be very good. Like how mammogram do have its own side effect, like painful and all that, but it's if you go by that, it's safe and it's rapid and all that. Then the healthcare system in that one should be cost effective. How Canada Health covered all of its population, all of its expenses and all that. Follow up and treatment of the positive screens, cost effectiveness, a sustained program. Disease prevention, health prevention. Let's finish up to this one and we can start from here. Disease prevention, I think we already discussed this much from that group. So disease prevention is basically talking about the health absence of a disease, trying to control the disease, trying to, like, we are talking or working on one particular disease, and target is only those groups and keeping them control that one. Okay, so like let's suppose if we're talking about diabetes, so that high risk population who are obese, who are indigenous, who are eating high, they are more prone, or their A1C or A1C is 6.1 or pre-diabetic. So working together to prevent that one. Health population is covering for everyone, maintaining the basic health, like maintaining them, giving them immunization, giving them screening. So building up the concept so they can do one yearly blood work. So these are the one they're talking about. Diverse and complementary strategies aimed in the network of the issues. Yes. Here is something. Let me provide. So we'll do this one. I would just wanted to do this one here. Health public policy. The purpose is to promote the sportive environment to enable people to lead a healthy life. So usually they're talking about healthy life. Government and non-government agencies work together to cover the cost, like how insurance works and how health card works together. The new field intervention ladder provides one way of the ranking of the level of intrusion, a need for the promotion of the benefit of the health promotion. So the ladder is basically for the new field one that works together to field for benefit the health promotion. What are the methods? Fiscal, where there are additional cost like taxes or tobaccos and all that, so people using it as less as they can. Then the legislative one, implementing the legal detergents, like putting the smoking bans. Okay, so it's not allowed, it's not allowed, it's not allowed. Then the social one, only providing affordable housing so everyone can afford it. Okay, so these are the methods to apply the public policies so everyone can follow them and everyone will stay on same page, although it is not work. So this one, then behavior change. Yeah, let's finish up into here. Then comes the behavior change. Behavior change is basically predisposing factors, knowledge, attitude, beliefs, values, and intentions. Then enabling forces, basically skills and sports, and reinforcing like all the professionals work together. Then the health education services to increase the knowledge and skills and promote health behaviors. Although it looks very easy, but when they try to give you questions, then it does not make sense, and it's becomes so complicated that you don't know where you read it from. That's why I'm saying whichever word you are reading it from, at least keep it in your head which topic did you read. Okay. Then health belief model, if you can, there's a six concepts, four concepts and cues to the action, and then health efficacy. If you want to read, it's good enough. If not, then at least know this one. There is a pre-contamination, contamination, then the action, and then the maintenance. Sorry, preparation, action, and maintenance. Those ones are talking about. Risk reduction strategies, where there's a risk reduction and harm reduction. Risk reduction is lower the risk to health without eliminating anything, like sun exposure, providing the sunscreen. Then the harm reduction for the needle, so preventing them to get the needle exposure. Community need assessment is basically define the community and understand its history, geographic characteristics, like telling them, okay, oh, this is a part of the Canada, it has got evaluated on this, and it is very good, and stay here, build your houses and all that. So, and then encouraging people to live there, and community, help increase the community, all of that one. So at least from here, stages of the change model and risk reduction, that's it. Okay, so we'll start from here, the measurement. So basically we will start biostats from tomorrow. And I think we will tomorrow finish the epidemiology, and in the next two classes we'll do the ethics. And with this, I think we'll be done. If there is anything or any topic that you guys want to study or want me to do it for you, then do